this video we're going to have a look at the eyeball itself. The eyeball, as you probably know, contains the optical apparatus, so everything that, well, at least physically in those terms of lenses and optics and focusing that allows us to see. I've removed the 6 extrinsic muscles that usually control its movements and a lot of its fascial suspensory apparatus. So now we can have a look at a couple of structures that are associated with it intimately. Here is the lacrimal gland. We're going to have a look at the innervation pattern for the lacrimal gland in just a moment. That is actually quite interesting. It does involve the facial nerve, and it involves, yes, it does involve another ganglion, which is called the pterygopalatine ganglion, and then a couple of relays to get these parasympathetic fibers, which are secretomotor fibers, because they help the lacrimal gland secrete tears. Yeah, so that's where they're called secretomotor fibers. Well, how to get those postsynaptic parasympathetic fibers to the eyeball, or actually to the lacrimal gland. So here's the lacrimal gland. Then we have a artery that is named appropriately lacrimal artery, and here is the lacrimal nerve. And technically speaking, the lacrimal nerve is actually a branch of the trigeminal nerve, so actually of the ophthalmic division. However, it also carries parasympathetic fibers that go and innervate the lacrimal gland. Down here we have some other branches. These are zygomatic branches of the facial nerve. Some of these will be responsible for mediating the blink reflex, so the efferent limb of the blink reflex, because these fibers will actually go and innervate the orbicularis oculi muscle, and the parts that are still left over here are called the palpebral parts. You have an orbital part which goes all the way around the outside of the eyeball, and you have a palpebral part which is directly on the eyelids themselves. So this is the palpebral part of the orbicularis oculi. Below that is another nerve. This is called the infraorbital nerve that will exit through a foramen called the infraorbital foramen. And this is purely a sensory nerve. Deep to the tarsal muscles, so the inferior and superior tarsal muscles, we'd actually also find the tarsus itself, which is kind of like a cartilaginous plate. We also have embedded in there, we have some tarsal sebaceous glands. You will secrete a kind of oily lipid secretion which will actually help lubricate the edges of the eyelids and prevent them from sticking together when they close. It also helps form a barrier that lacrimal fluid doesn't cross when produced in normal amounts. When the production of lacrimal fluid from the tear gland, of course, is excessive, as you can imagine, it'll spill over the barrier. The eyelashes here are called cilia, and they will just be on the margins of the upper and lower eyelids. And they also have large sebaceous glands associated with them, and they're called ciliary glands. Then we can call the regions here the junctions of the medial and lateral margins of the eyelids. They are respectively called the medial and lateral palpebral commissure that define the angles of the eyes. You can also find ligaments there, like for instance here the medial palpebral ligament. There's a little fleshy mound in the middle here, which is called the lacrimal caruncle. It's like a little mound of round, moist, modified skin. And around it here, you see this reddish appearing structure. This is the lacrimal lake. It's basically a shallow little reservoir for tears before they then drain into the lacrimal canaliculi, and from the lacrimal canaliculi into the lacrimal sac, and then from the lacrimal sac all the way down through the nasolacrimal duct. Oh, we go down here. That would be a little bit further down here, which then will empty into the inferior meatus of the nose. So if you look at the eyeball from laterally, we can see that it's continuous here with the outer sheath of the optic nerve. Yeah, well, specifically what is continuous with it? It's actually the outer fibrous layer of the eyeball itself. You can also see back here is the common tendinous ring, which is also called the annulus of Zinn, which forms an important attachment sites for many of the extraocular muscles that will actually move the eyeball. So if you think about the construction of the eyeball, it actually has 3 layers if we think about it as a layered structure. It has a fibrous layer, a vascular layer, and an inner layer. Probably best to highlight this on a different type of diagram which has been made by the illustrators from 3D4 Medical. So here you can see the 3 different layers. Okay, so the fibrous layer, or the outer coat, consists of the sclera and the cornea. The sclera and cornea are continuous with each other. The sclera is also described as the white of your eye. And in addition to that, as it is opaque, of course, it will not allow any kind of light to go through. So it'll cover about the posterior 5/6 of your eyeball. The last bit is anteriorly the cornea. And another function, or the, duty of the sclera, so to say, is that it'll provide an attachment site for the extrinsic, so the extraocular, and also the intrinsic muscles of the eye. The anterior part, as I said, is the cornea, and this is actually also innervated. So we can regard the cornea as being the transparent part of the fibrous layer, which covers the anterior 1/6 of the eyeball. Technically, we would say that you can actually see the sclera. It is visible through the bulbar conjunctiva as the white of the eye. If you look at someone's eye, you have, of course, the iris and the pupil, and around there is the white of the eye, sometimes a little bit. You can see some red from the arteries in the white of the eye, but actually it is covered, the sclera is still covered by bulbar conjunctiva, which is transparent there, so you can see right through it. Also, if you look at this, you can see that the cornea has a greater convexity than the sclera, so it seems to protrude a little bit from the eyeball. It seems to stick out just a little bit here. And one of the main differences between the two parts of your fibrous outer coat here is just in terms of how regular or irregular the arrangement of the collagen fibers are that they are made up of. And in addition to that, of course, the degree of hydration of these collagen fibers. The sclera is actually fairly avascular, but the cornea is entirely avascular. So the cornea is only going to get its nourishment from capillary beds that are all the way around it, and from fluids on its external surface, like for instance the lacrimal fluid, or fluids on the internal surface, which is called aqueous humor. Don't worry, we have another slide for that one coming up. The lacrimal fluid on the outside also will help provide oxygen for the cornea. In addition to that, to protect our eyesight, we have to have a very, very sensitive cornea. This is why it's very sensitive to touch, and this is mediated via a branch of the trigeminal nerve, actually from V1, the ophthalmic division of the trigeminal nerve. So even a very, very small foreign body, like a dust particle, will elicit blinking and the flow of tears, and sometimes even severe pain. If the corneal surface dries out, that's actually really dangerous because you can get an ulceration. In the worst case, of course, this can lead to blindness. And we can also name the junction between the cornea and the sclera. It's actually called the limbus, which is the angle formed by the intersecting curvatures of the cornea and the sclera. So here's the cornea and there's the sclera. And there's going to be an important little area here, the corneoscleral junction, when we think about the aqueous humor, which nourishes the cornea from behind it, yes, from inside the eyeball. We'll get to that one in just a little bit. The second layer here is the vascular layer. Okay, so you can see here is the vascular layer, and also called the middle coat. And so in here you have something called the choroid, the ciliary body, and the iris. So the choroid is a usually dark reddish brown layer that's between the sclera and the retina. You can see the retina over here on the right. And it has a pretty well pigmented and dense vascular bed. Larger vessels are located pretty close to the sclera, and the finest vessels, like the capillary lamina of the choroid, is called the choriocapillaris, which is a pretty extensive innermost capillary bed that is right next to or adjacent to the avascular light-sensitive layer of the retina, which is supplied by it with oxygen and nutrients. An interesting little factoid is, in life, it is actually so engorged with blood that it has the highest perfusion rate per gram of tissue of all the vascular beds in the body. That's quite impressive, isn't it? It's also the layer that, if you think of flash photography, the red eyes that happen, well, this is the layer, the choriocapillaris, that is responsible for this red eye reflex. And although the choroid attaches pretty firmly to the pigment layer of the retina, it can fairly easily be stripped away from the sclera. So if you have the sclera, the choroid, you can peel it off the sclera fairly easily, but it's firmly attached to the retina. And if we're moving anteriorly, the choroid becomes continuous with the ciliary body, which is basically a ring-like thickening. I'll show you on the next slide. Here is the ciliary body. It's a ring-like thickening that goes all the way around the eyeball, on the anterior aspect, of course. And one of the functions of the ciliary body is to provide an attachment for the lens, because the lens is basically suspended by little fibers called zonular fibers. That's important because by, well, either contracting or relaxing the ciliary body, the muscles of the ciliary body, we can change the shape, and with that also the refractory index of the lens, which is important for accommodation so that we can actually see things in focus. Going back to this one, we can see down here, these are ciliary processes. Let me just quickly pull up a more elegant picture. Here are the ciliary processes. So these are important because they secrete, this aqueous humor. So for an overview, here's your cornea. This is called the anterior chamber. Back here is the posterior chamber. This is the ciliary body. These are ciliary processes. These are zonular fibers, and here is the lens. And these ciliary processes will secrete this aqueous humor that will fill the anterior and the posterior segment of the eyeball. Also belonging to this middle layer of the eyeball is the iris. And the iris basically not only is responsible for the color of your eye, but it's also like the aperture of a camera. This is a very thin and highly contractile diaphragm with a central aperture, which we will call the pupil. So all the light that falls in through the pupil and reaches the retina, will be determined by the opening of the iris. So when a person is awake, the size of the pupil is going to basically vary continuously as the ambient light around this person changes. And so we have two opposing forces. It's kind of like yin and yang. You have one force that will open up or widen the pupil, called the dilator pupillae, which is innervated sympathetically. And then the contractile parts is called the sphincter pupillae, which is under parasympathetic control. So to constrict the pupil and let less light pass through, we're going to have postsynaptic parasympathetic fibers that go to the sphincter pupillae. These fibers will actually originate from the oculomotor nerve. They will synapse in the ciliary ganglion. Now they're postsynaptic, and then they will actually make the pupil constrict. The postsynaptic sympathetic fiber will have only passed through the ciliary ganglion. These are sympathetics. They actually have synapse in the superior cervical ganglion. Okay, so although the fibers will travel through the ciliary ganglion, they will actually not have synapse there if these are sympathetic fibers. The sympathetic fibers will have synapse, as I just said, in the superior cervical ganglion. So if we can put this all together, the sphincter pupillae will be innervated by parasympathetics via the ciliary ganglion, and it leads to constriction or closing of the pupil to let less light in. And the dilator pupillae is innervated via the superior cervical ganglion with sympathetic fibers, leads to wide opening of the pupil. There's one thing about it though, if you have your pupil dilated due to a sympathetic response, like getting scared or something like that, it's instantaneous. However, the paradoxical thing about this is, well, in a dark room, your pupil also will dilate over time. However, it takes much, much longer. So to make this a little bit more palatable, I have added some animations, okay? Please note here, I've just added these little diagrams here that's supposed to resemble the eye with a dilated pupil, okay? So let's add something to the equation. We'll add sunlight to the equation. So here's the sun, and so the sunlight will be perceived by the retina, and from both directions it will actually go via the optic nerves and something called the retinohypothalamic tract to the pretectal nucleus, get relayed to the Edinger-Westphal nucleus, and then from here on, via oculomotor nerve parasympathetic fibers, to the ciliary ganglion. Okay, so you see this is a dashed line. Usually, if we are drawing sympathetics or parasympathetics in this case, we'll use a dashed line if it's presynaptic, and it's running to the ciliary ganglion. And there, the synapse occurs, and after the synapse occurs, on both sides in the ciliary ganglion, we will have the postsynaptic parasympathetic fiber going to the sphincter pupillae, and you can see the pupil is constricted on both sides. Note one more thing here. Here's the optic chiasm, or the chiasm opticum. You can see that some of the fibers from the left eye cross over to the right side, and vice versa. Well, that means that even illuminating one eye will lead to a reflex in both eyes. It's also a good way how you can test that everything's actually working. If you put your hand in between someone's eyes as a barrier and shine a light only in one eye, well, you should actually have a consensual pupillary light reflex. So let's rewind the animations one more time. We're starting over. The pupils are dilated right now. Here comes the sun and shines onto the retinae via the optic nerves, the retinal hypothalamic tract. Information gets relayed back to the pretectal nuclei, from there to the Edinger-Westphal nuclei. And then we have the parasympathetic presynaptic fiber going with the oculomotor nerve to the ciliary ganglion, synapse here, and then you have your postsynaptic parasympathetic fiber going to the sphincter pupillae or constrictor pupillae to make the pupil small. And this happens on both eyes, even if you only shine the light into one eye. Now moving on to the inner layer of the eyeball. The inner layer of the eyeball is going to be the retina. And grossly we can actually distinguish two different functional parts with distinct locations. So you have an optic part of the retina, which is going to be light sensitive. Of course, this is going to be the part that contains the rods and cones that we need to create images through vision. And there's also a pigmented layer. So the neuronal layer is actually the one that's light sensitive, and the pigmented layer consists of just a single layer of cells that will help reinforce the light absorbing property of the choroid by reducing the scattering of light throughout the eyeball. The non-visual retina basically transitions, or actually the visual retina transitions to the non-visual retina at the so-called ora serrata, which means the serrated edge. So it's basically just the anterior continuation of this pigmented cell layer and a layer of supporting cells. All of the non-visual retina will extend further anteriorly all the way over the ciliary body, so the ciliary part of the retina, and the posterior surface of the iris, which is called the iridial part of the retina, all the way to the margins of the pupil. Clinically, the posterior part of the eyeball here is referred to as the fundus of the eyeball, or the ocular fundus. And the retina of the fundus includes a distinctive circular area back here, which is called the optic disc. At the optic disc, there are no rods and cones. That means that this is actually, well, also called the blind spot, because light is falling on there. Well, there's no way to detect, and there's also ways how you can find out where your blind spot is. You can probably Google that and find out how to do it. It's actually quite fun. However, the optic disc is where cranial nerve number 2, the optic nerve, enters, and this is why there's no room here for the rods and cones. However, what enters here as well is the retinal, or the central retinal artery and vein. So here comes our first little clinical correlation, because as the central retinal artery and vein come into the optic disc, and as all of these branches are going to be terminal branches to the internal retina, you can imagine if you have too high pressure within the eyeball, this can squeeze off and occlude these arterial branches, and so this is why one of the consequences of glaucoma can be blindness. In addition, if we think about the blind spot and the optic disc, well, we already know that this is from where all the central retinal artery and vein branches radiate out, and from here on all the information, the visual information, is gathered and led back via the optic nerves towards the brain. And next to the blind spot is a little area called the macula, or macula lutea, for the yellow spot. The yellow spot has within its center a little region called the fovea centralis, which is actually the region of the most acute vision. The reason why the macula is actually called the macula lutea, or the yellow spot, lies in the fact that when the retina is examined with red-free light, the macula lutea actually looks yellow if looked at through a ophthalmoscope. And within this little region, this is where we find a variety of special photoreceptor cones that is important for the acuity of our vision. And within the yellow spot is this tiny little, about 1.5 millimeters in diameter, This tiny little region, the fovea centralis, basically means in Latin the central pit. That is the area of most acute vision, and this is where you have a high density, or an especially high density of these special cones. So now let's move along to the refractive media and compartments of the eyeball. On their way to the retina, light waves are going to have to pass through the refractive media of the eyeball. That means through the cornea, through the aqueous humor, the lens, and the vitreous humor. At least that's the order from anterior to posterior. The cornea is our primary refractive medium of the eyeball. That means it'll actually bend light to the greatest degree, and thereby creating and focusing an inverted image on the light-sensitive retina in the fundus of the eyeball. Your aqueous humor, which can also be shortened to aqueous, will occupy your anterior segment of the eyeball, and remember that the anterior segment is subdivided by the iris and the pupil. You have the anterior chamber of the eye, which is going to be the space between the cornea anteriorly or in the front, and the iris and pupil posteriorly. And the posterior chamber of the eye is going to be between your iris and pupil anteriorly and the lens and the ciliary body, from which it's technically suspended, posteriorly. As you may recall, this important nourishing solution, the aqueous humor, is going to be made in the posterior chamber by the ciliary processes. That'll pass through the pupil into the anterior chamber and provide important nutrients for the avascular cornea and the lens. And where does it drain out? If you said the iridocorneal angle, or the canal of Schlemm, the scleral venous sinus, then you are right. The humor is actually removed by something called the limbal plexus, which is just a network of scleral veins close to the limbus, and they drain in turn into tributaries of vorticose and anterior ciliary veins. The lens is posterior to the iris, as you can see, and it's anterior to the vitreous humor of the vitreous body. So it's a transparent and biconvex structure, and it's enclosed in a capsule. That's really important because the high elasticity of this capsule of the lens makes it possible to anchor it via these zonular fibers that go all the way around it. And so basically they all together will collectively constitute something called the suspensory ligament of the lens, okay? Because they basically like encircle the entire lens. And although I stated earlier that most of the refraction is produced by the cornea, well, the convexity of the lens, particularly on the anterior surface of the lens, varies to fine-tune the focus of near or distant objects on the retina. So if we were to take out the lens and have it unattached, it would basically assume a near spherical shape. So in other words, without the, well, external attachment and the stretching that you can see over on the left picture, it says relaxation, taut zonular fibers, flattened lens. Well, and so basically the isolated lens is nearly like a marble. It's nearly completely spherical. However, once it's actually attached via zonular fibers to the ciliary body, then it can be stretched. And it'll be stretched if there is no nerve stimulation that would make the muscle contract. When the parasympathetic fibers stimulate the ciliary muscle to contract, it'll release the tension on the capsule of the lens, and the lens can then kind of become more spherical, as you can see on the right side. And as it becomes more spherical, it moves the focal point further anteriorly so that we can actually create an image on the retina. And this entire process is called accommodation. And like with many bodily functions and processes, by the time you reach the age of about 40, the ability of your lens to change its shape becomes more and more restricted.